On this call is listening in using your computer speaker system by default. If you would prefer to join over the phone, just select telephone and the audio pane on the right-hand side of your screen, and the dial-in information will be displayed. You'll have the opportunity to submit questions during today's presentation by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and, time permitting, address them during the Q&A session at the end of today's presentation. Also, please note that today's slides will be shared in a follow-up email after this presentation in case you want to review again or share with any peers. Before I introduce today's speaker, I would like to note that today's webinar is the fourth webinar of iHealth Innovation's MACRA Final Rule series. Please keep an eye out for upcoming Final Rule webinars, including a MACRA Final Rule overview and additional specialty-focused webinars for orthopedics, radiology, as well as cardiology. If you're interested in attending the cardiology webinar, please be sure to check out your invites or iHealthInnovations.com to register for the cardiology webinar today at 3 p.m. Eastern Time. I would now like to introduce Justin Barnes. Justin is a corporate, board, and public policy advisor. In addition, he's Chairman Emeritus of the HIMSS EHR Association, Co-Chairman of the Accountable Care Community of Practice, and partner at iHealth, where he assists organizations with industry strategy and leadership. Justin is also the host of the weekly syndicated radio show, This Just In, on Healthcare Radio and Business Radio X. Justin has formally addressed or testified before Congress, as well as the last two presidential administrations, on more than 20 occasions. He's appeared in more than 1,200 journals, magazines, and broadcast outlets. With that, let me turn today's presentation over to you, Justin.
Thank you very much, Alex. And I actually don't have controls, Alex. Something happened here, and I do not have controls. I don't know what the issue is, so I may have to pull up you have to drive my slides, and I apologize. I certainly want to cover my content. There we go. All right, that worked. I think everybody should see my screen now. Is that correct?
Yes, go ahead.
Thank you. So thank you very much, everybody, for taking the time to join us. If you ever joined one of our webinars before, we do cover a lot of ground, and I appreciate, again, everybody's time here. And this is going to be focused on primary care. So primary care, including OBGYN and pediatrics. So that would be family medicine, internal medicine, general practice as well. But also we have, I think it's December 1st, is going to be our next webinar for the full MACRA strategy and a lot of the final rule overview. But today we're going to dive in specifically to how it affects primary care and, again, OBGYN and pediatrics. So you can also join if you want another webinar or share with any peers. We'll be having the December 1st one. But I'd like to take a quick step back and look at a practice kind of as you're a business, but also look at some general best practices for how to operate and create more efficiencies within the organization, because that's an essential step to taking on MIPS and the QPP and any other quality reporting initiative. It's not just about going out there and trying to stave off a 4% cut or even try to get an extra couple of 1%. You really got to look at your overall organization, because there's a lot of efficiencies when you look at the amount of money that can be generated by optimizing your revenue cycle. It's like it's like 9 to 1. Like 90% of the money that you can make in the next couple of years is going to come from just optimizing your revenue cycle and making sure that your practice is flowing properly and you have the right best practices where you need to. And I'll talk a little bit about that. And also how you leverage innovation. I'm going to talk about that here in a moment before I get to the MIPS and the quality payment program, because this, again, where for average practice, anywhere from $100,000 to $300,000 of additional revenue and cash flow, and then you layer on the incentives from MIPS and the QPP, the quality payment program, you're going to be very well positioned for the future of healthcare. So very quickly, I talked about the revenue cycle, and I'm going to talk about some details there in a moment. But look at new services and care delivery options that are specific to your specialty. And also, I'll talk a little bit about that later on and later on in the presentation. But there's processes, services, and innovation that you can deploy today, pennies on the dollar, that make it easier to do business with your organization and leverage innovation and technology. Specifically, scheduling, one of the biggest issues for patients and for practices is making sure that patients have easy access to scheduling, easy access to making appointments, and really conducting business and doing business with your organization. It sounds like, of course, Justin, that's no problem, that's simple. It's not, because when you survey your patients, 40 to 50% traditionally say it's hard to either make an appointment, or it's difficult to schedule, or get somebody on the phone, or it's a back and forth on a bunch of phone calls. And it doesn't have to be like that. There's some really neat innovations that you can roll out that will help with that. Will increase your throughput, increase your patient flow, increase revenue and collections at the bottom line. Also, appointments. There's a direct correlation to patient satisfaction, which is going to be a larger revenue stream later on for your practice, including within MIPS. But your appointment wait time is, again, directly tied to satisfaction and also how patients value the care that they're receiving. So if it's more than 15, 20 minutes of wait time, it begins to affect their satisfaction. 30 to 45 minutes of wait time really inhibits their satisfaction, which then is a deliberate and delineation to their value of the care that they received. These are all important metrics to a practice long-term and also to a patient. So you want to make sure patients are seen on an adequate basis, on a regular basis, in a timely manner. Mistakes happen, things happen, and delays occur. No problem at all. But on a regular basis, patients aren't waiting more than 25 or 30 minutes. And then also make it easy to conduct business in a way of paying your practice. And that's a couple of different ways. Online bill pay, or statements that are very easy to use, or easy to read and understand exactly what they owe, payment plans offered. There's ways to increase your pay, increase your collections, but making it easier to conduct business in this way with your practice will help you dramatically. And some systems that actually you take a nice cut of the payment process. So it's beyond just the full payment. So there's a lot of innovations out there today that I want to make sure we highlight and we talk about. Now, one last slide here in the revenue cycle. Things that you can look at even today is you want to look at the provider workflow, and you want to audit provider workflow. When we say that, what do we mean? Really talking about looking at documentation to make sure there's no under-documentation, or that you're getting paid for what the provider did. Everybody's working hard. We want to make sure that you keep the money that you've earned. So there's assessments, questionnaires, evaluations, service tests, and screening to make sure that's all being captured at the right time with the provider's workflow. And a lot of that can be captured inside the EHR if you're using health IT and any technology. But also, not only does that make sure you get paid better and that you're capturing that information properly, but also that scoring is all counting towards your MIPS calculations. So you actually qualify for the MIPS incentives, not only avoid the 4% cut, but also be able to get a 1, 2, or 3, or even 4% increase. So a lot of opportunity there on auditing provider workflow. Also, random chart audits, not just by the team that's always doing the billing, but also by outside expert coders. These people pay for themselves, because when we go in and we do a chart audit, or we partner with a practice, you can find, usually, if we bring them an extra $150,000 or so in revenue, $50,000 of that additional revenue comes from just looking at using the right codes and making sure that, basically on the screen right now, looking for missing charges. We'll pull charts, looking for consultations or no notes or wrong provider noted, or downcoding or upcoding and wrong ICD-10 codes used, missing modifiers. So these are great ways to capture more revenue. And like I said, usually 1/3 when we do auditing and we bring more revenue to practice, that's where we find it. We find it in the coding. Also, it prevents rejections, denials, and audits, which are very, very key. So again, this is by an expert biller, not necessarily a normal billing team. And when you're setting up these new programs and about to participate in these programs, keep the future in mind. So you want to make sure that you're using the right codes for the right program, and then also make sure it's integrated in with your EHR. This is a lot of work that can be done on the front end, so it makes PQRS easier, MIPS participation easier, any alternative payment models, and certainly other quality reporting initiatives. All that information can be captured inside your EHR, and also it will reduce clicks, which is very key. And all of these, our goal is to also, when you're using technology, to make sure it's easy to use, the workflow is inherent to the way that you want to practice medicine, and then also that we're capturing the right information at the right time. And that does reduce clicks. Credentialing, monitoring PAR and non-PAR care providers. The bottom line there is companies like us, we play the game with the payers. That's very important. When you get out there, we have several customers that the insurance companies, what they do is just their standard business practice is they unenroll all the providers every single month. We have to re-credential every single month. One of our larger customers, we brought an extra $9 million annually now to their bottom line by playing that game figure out what the game the payers are playing and then playing that game. And so we re-credential every single month all of the hundreds of physicians. But that's just part of our process, what we have to do, and that brings, like I said, an extra $9 million to an organization. And on the practice side, it could be an extra $50,000 to $150,000, really depending upon the size of the practice. And also optimizing collections with eligibility verification, prior authorization, certainly in the specialties, you got to make sure that this is a lockdown process, and also we're re-reviewing every single month authorization and denials. And managing fee schedules, looking at make sure that you're getting paid to what you have already negotiated with the payers. And you do this, you balance these fee schedules and look for these variances every 6 to 12 months. The best practice that we deploy, and rarely do the payers overpay. It's traditionally they're always underpaying. But also another best practice here is if you're looking at bringing in equipment, you can actually ask a partner to do a little bit of an audit and make sure, based on your fee schedules, that you're going to have the right ROI. I'm sure people are walking in there every single day trying to sell you new equipment and upgraded equipment, but you got to make sure your reimbursement matches to pay their ROI. They'll come up with these high ROI numbers, but your reimbursement and your current fee schedules won't match. So I think on your screen right now is just a few of the denials that we've gone through in primary care and internal medicine. Just because of our time frames today, this is a very short and concise 45 minutes that we have together. We're going to share all of these slides with everybody the next 24 to 48 hours. So again, I'm not going to go through all of these. This is just some of the best practices that you can look for, and we can certainly, when you have a co-sourced partner or someone, to go in there and look for some of the best practices to avoid denials that we see pretty regularly. But usually with each specialty, we have anywhere from 30 to 40 of these that we look out across their workflow, across their specialty, and deploy. On a pediatric side, very similar. Again, not be able to go through these in detail just because of the time that we have. But again, we'll be sharing all of these slides with you. And then obviously any specific questions that you have, please feel free to follow up. And I did want to make one note. I have received a couple of questions just through social media from different of the attendees. And we will be following up with all of your questions. If you don't ask them today, and you do reach out to us on social media or any way, we will respond to all of your questions that you have. We'd love to partner and help you with that. So now, diving into some of the value-based care initiatives and incentives, I want to address, obviously, specifically MIPS, but also other alternative payment models and quality reporting initiatives that might be available in your state, in your community. Now, from a high level here, we're all aware that the final rule for MIPS, the merit-based incentive payment system, came out back in October last month. But specifically, I want to let everybody know that this is actually a program that everybody can be successful with. So, and I'm talking about some of the qualifiers and other components, but if you're taking the time to be with us today, to study the rule, the odds are you're going to be very successful with the program. So again, I wanted to alleviate anybody's concerns. You're probably not going to get a 4% cut, and hopefully you'll get a 1, 2, or even 3, 4% increase. So let's go through the options and why I'm so confident in that. Option 1 allows providers to report 1 quality, 1 improvement activity, or 5 advancing care information measures to avoid a negative payment. This is very, very simple. So just 1 quality measure, 1 improvement activity, or 5 advancing care information measures over a 90-day period to avoid negative payment adjustment. So anybody that's ever gone for PQRS, meaningful use, or any other quality reporting initiative, probably those are more difficult than qualifying for option 1. So everybody, certainly if you have a good partner like us or even a good EHR product, you're probably going to be in very good shape. We're helping a lot of people with not only option 1, but really moving down option 2 and 3 and a little bit of 4. So option 2 allows providers to submit measures and activities data for 90 days. Then this is a mixture of quality, improvement activities, and certainly the 5 advancing care information measures over a 90-day period. That means you can start after January 1st, because I think everybody knows this MIPS and the quality payment program starts January 1st, 2017, and in 42 days or 43 days or so. So it's coming up right on us. But again, if you go for option 2 or even option 1, you can start anywhere, after January 1st and be just fine to earn a certain and neutral or even a positive payment adjustment. So again, option 2, a mixture of quality measures, a mixture of improvement activities, and the 5 ACI measures for 90 days or more, and you'll be good to go. And I'll walk through all those best practices here in a moment and exactly what those measures and activities are here in a moment. Option 3, practices that are ready to go, certainly around January 1st, and you've got all that data and you're going to be able to capture that data and build a report on that data. If you're using one of the leading EHRs out there, one of them that I'm most familiar with now, eClinicalWorks, I've seen all their MIPS calculations and their dashboards. They're doing a very good job. But I'm sure other ones, I come from Greenway days, so Greenway's had the Prime Suite products. Usually it's pretty good. I'm sure they're going to have their products ready. But if you're using a top 5, a top 10 EHR, you probably should be in good shape with being ready to go near January 1st if you want to. And that's to really work towards a positive payment adjustment, saying up towards 3 or 4%. But again, I think most people will fall into the option 1 or 2. Certainly, I'm working with a lot of people that fall into option 3. And option 4 is another set. That's kind of the ones that are in advanced alternative payment models. And those would be Medicare Shared Savings, ACO Track 2, Track 3, CPCI, one of the oncologies. There's several in that regard. But I don't know if there's any of those on the phone per se today, but that's option 4. So again, a quick recap here. But if you want to go to the MIPS track, which about 90% of care providers will go down the MIPS track and the MIPS angle, that's 4% increase, up to a 4% increase in year 1, up to a 5% in year 2, 7% in year 3, and 9% in year 4. And these are cumulative. So this really adds up over a period of time. And the other ones, there's mixtures of hybrids that you can do, the non-advanced and the advanced APM, which is 5% plus other rewards. But I said 90%, I think most of them on the line today are going to be going down the MIPS path. And just as a reminder, all clinicians got a 0.5% under Medicare, got a 0.5% increase in their fee schedule in 2016, and again we'll go in 2017, 2018, and 2019. So there is a natural increase, and certainly you want to stave off any cuts by participating in the MIPS program if you qualify. And I'll go through the qualifiers in a moment. Actually, I'll touch on them right now. So the way that you know if you qualify is if you have more than 100 Medicare patients or $30,000 in allowables, or I think it's a first-year resident or first-year physician at a residency school, you can, a residency program, you can be exempt from the program. But I think most of the people on the line right now would qualify, at least from what I understand. So going through the performance categories, the cool thing is that for year 1 in 2017, they reduced it down to 3. So you have quality, advancing care information, and improvement activities. Quality replaces PQRS, and that will account for 60% of your total score. Advancing care information will replace meaningful use, and there's 5+ advancing care information measures. And what's really neat about this is I'm going to show you the flexibility in all these programs. So for quality, you only need to do 6 measures. And when I say that, like family practice, which we'll talk about in a moment, has 55 to choose from, but you only need to do 6 for full credit. Same thing on advancing care information. You'll have 11 or so to choose from, or 12 or so, but you only need to pick 5. And improvement activities, there's 93 to choose from, and you only need to pick either 2 or 4, depending upon a high-weighted one or a medium-weighted one. So again, lots of opportunities. So ACI, 25% of your score, improvement activities, 15%. You total them all up, it's 100% of your weighted score for 2017, and then in 2018 they'll layer on a new category that replaces the value-based modifier. But again, very simple. So here's a kind of another piece of what I just discussed. So on quality, you have 6. You have to find or pick 6 quality measures for full credit. Again, for the first year, if you just want to stave off any cuts, that 4% cut, you only need to report 1. But if you want full credit, you have 1 quality measure. 6 quality measures. But you'll, I guess, for example, family practice, you'll have 55 to choose from, and you will need to pick 1 outcomes measure if it's applicable. And I think it's applicable to everybody on the line except for the pediatricians. And if not, then you can just pick another quality measure, another or high priority measure. And then at the bottom here you see, so family practice has 55 measures to choose from. You only need to pick 6. Internal medicine has 37. You only need to pick 6. OBGYN has 24. only need to pick 6, and pediatrics has 18, and you only need to pick 6. So again, a lot of flexibility there. So you can find the quality measures that best work with your workflow, practice, and obviously specialty. But also, if you're already participating in PQRS or meaningful use or anything, you're going to find a lot of these you've already been doing on a regular basis, which is terrific. Now, on the ACI side, the Advanced Care Information side, if you're using a MIPS certified EHR, then you'd go for option 1, and you have to report on 5. If you do not have a MIPS certified EHR, then you go for option 2, and 4 would be required, and then you have to go pick one, additional one out of the 11. That'd be done through a registry or some other way. But you need to have more flexibility there based on having 15 measures if you actually have a MIPS certified EHR. Now in the proven activities, up to 93 to choose from. You only need to do 4 medium weighted ones or 2 high weighted ones to be able to qualify for this. So again, lots of flexibility, 93 total. And we're actually going to walk through and show you some of these here in a moment. But some real quick takeaways before we dive into some of the specialty specific numbers and calculations. This is all pick your pace. So again, a lot of flexibility. You can go for 90 days, you can go for 180 days, 270 or more. Highly flexible. So you saw all the variable objectives that you can go through. Say 55 for family practice. You only need to pick 6. So it's based on high flexibility between objectives, measures, and whatever best fits your practice, your specialty, and your workflow. And also, it's not all or nothing like meaningful use. You can get partial credit and bonuses available to avoid penalties and also increase your payments. So you can participate as much or as little as you want, and just a little bit staves off any 4% cut. If you want to participate in a little bit more, you can get a 1, 2, 3, or 4% increase. So it's just a great strategy for everybody. A couple weeks ago, I put out a 4-point plan for MACRA and MIPS success. That covers a little bit about the financial stability. Again, you want to stabilize your revenue cycle because when I show you these incentive payments that you're going to get potentially from CMS around MIPS, they're not as high as optimizing your revenue cycle. It's 8 to 1 or 9 to 1. So there's a lot of money to be had today just by optimizing and streamlining your revenue cycle and your practice, and then have those other incentives pick up. Clinical success, focused on documentation, population health and care coordination. All are feeders for more quality incentive money and outcomes-based payments coming today and also certainly tomorrow. Technical success, which is you want to optimize your health IT infrastructure. You want to make sure that your dashboard is set up to look at your financial and clinical analytics. You want to make sure that you have your EHR capturing information at the right time with the right code so you can get paid at the highest amounts. I call it coding optimization. It's just a lot of best practices there to increase your revenue, 5 to 6% just on their coding. It's a lot of money. It's pretty significant. And staff success, and to make sure that your staff is aligned, they know where you're going, and everybody's bought in to how healthcare is evolving. It's not going back. It's not going to paper. We're not getting rid of any of this. It's all trajectorying in the same direction and at another level towards outcomes and quality-based payments. So let me touch on that quickly, only from a standpoint of the elections. People are asking me since President-elect Trump is about to take office, what does this mean for MACRA and these other programs? Bottom line is MACRA was passed in 2015 as a bipartisan bill through Congress and signed by the President. There's no one out there, no key stakeholder, no member of Congress, or even anybody in the Trump administration is asking to repeal or replace anything to do with MACRA. Health insurance reform, the ACA, most certainly. That is on the chopping block, and you're going to see, I don't think you'll see a full cut, but you're going to see individual pieces being addressed by President Trump and the new Congress. But there's no one, not a single chirp from anybody talking about MACRA or these quality of payment programs. These actually were Republican tenets in Republican legislation before the Obama administration picked them up and put them in the ACA legislation. So this is, and all of this has strong bipartisan support. Just want to delineate between the ACA, Obamacare, which probably will have changes coming, but not MACRA and not the MIPS program. But if you want to look at my 4-point plan, there's a link right here. Again, we'll share all these slides out with you, and you can click right on the link or just go to Becker's Hospital Review, and you can find it. It's posted now. So I'm going to talk about some of the incentives and what it means to everybody specifically that's on the phone today. So for family practice, say an average 6 clinician practice, $14,000 your first year, about $18,000 your second year, $25,000 your third year, and $32,000 your fourth year. And again, this is all cumulative, and so I'll show that to you here in a moment. So it's just money that's pretty easy to attain, and you just don't want to have those cuts. Because again, if you ignore the program and don't go for it, those are your annual cumulative cuts that'll start to occur. And so here's what it looks like cumulatively. So $14,000 the first year, then $32,000, then $56,000, and $89,000. You just don't want that cut after 4 years. So you want to have that move towards a positive payment adjustment, which is on the right side of your screen. You want potential pay increases. You don't want those flat cuts. So the cuts are not incremental. I mean, the cuts they really could be more dramatic. So it's just good to pay attention, and you joined us today to do so. So on the family practice side, again, I'm going to go through a bunch of slides here because we just want to show you what these measures look like by specialty. But we don't have time to cover all 55. But again, we'll be sharing all of this content out with everybody, and you should be in good shape. So I'm going to roll through these kind of quickly. But again, these are the 55 to choose from family practice. And a lot of these you've already been doing part of PQRS or say, and part of PQRS for this regard. But when you get to the advancing care information, you're doing a lot of those measures as part of meaningful use. So again, if you've done PQRS or anything like that, you've already seen a lot of these. These are already part of your normal workflow. And again, I can't spend time on each one because we have so many different specialties on the line, and there's 55 measures, and I want to get to all of them. But we'll be sharing all of this with you, and all of our content's always posted on our website, and you can go back and pull any of these down, share them with the new peers or anything that you would like with that regard. And we'll be doing another primary care one in December. We're going to keep these going every single month because there's so much interest in these. And again, I apologize that I can't stay on any one screen. We just want to show you that these are very tangible. They're easy to find. We've actually captured them, and we actually partner with all of our practices and help them roll these out and also pick the right specialties. I think that's one of the biggest things in some of the best practice consulting side and advisory side is you'll find people who actually tell you, here, you only need to pick 6, but here are the 10 or 12 that best fit your specialty and your workflow. And that's really what a good partner will do for you here. So again, these are all 55. I can't spend time, but we'll be sharing these slides out with everybody. Now, internal medicine. So for, say, there's 7 clinicians in internal medicine practice, your average reimbursement, or not reimbursement, but your incentive payment will be about $26,000. And again, these are cumulative, so 26 the first year, 33 the second year, 46 the third year, and 59,000 the fourth year. So this is money that's available to you. And also cumulatively. So it goes 26 to 58 to 104 to $163,000. So again, a lot of money that you wouldn't want to leave out there for average practice. And again, these are all variable based on your Medicare population and how you want to set up your MIPS and the quality attainment program systems. And a lot of the best practices that we like to talk about are make sure that you're, again, setting up the EHR properly, and that you're also setting up your dashboard so you can calculate and see exactly how you're doing. We check in usually monthly with our practices, if not quarterly, to see how they're doing and see what they need to change and get better at, and what can we do to assist. Now with the internal medicine, there are 37 quality specialty measures to choose from. Specifically, you only need to pick 6. And I'm going to do the same thing. I'm going to roll through all 37 here so you can see them. But again, if you've done PQRS, you should be in good shape. We're in controlling high blood pressure. That's an outcomes measure. And many internists do that with many other patients. And again, we'll be sharing all these slides with you. You can go through this at your cadence, at your leisure, at your speed, when you want. But we just want to make sure, I think it's very important. I think we're the only company out there that is actually showing you everything. We want you to be, because a lot of this seems black box. We're not quite sure where to start. Well, you've already found a great place to start, but also we want to show you everything. So for internal medicine, we're showing you everything that you need to see, and really kind of a blueprint of what you need to do to be successful with MIPS and the quality payment program. Now for OBGYN, say there's 10 clinicians in a practice, about $12,000. Again, their Medicare population could be a little bit lower, and that's why the incentives are a little bit lower there. But $12,000 the first year, $15,000 second year, $21,000, and then $27,000 the fourth year. Cumulatively, up to $75,000 over 4 years. So again, it's just money that you don't want to leave out there, and you certainly don't want to have those financial hits or financial cuts come to you. And also, this is not just about what CMS is doing. And if you ever heard me speak before, every payer is moving in this direction. Every commercial payer, every plan. So if you want to stay on panels, stay a part of referral streams, participate in how healthcare is evolving in your community, different accountable care structures or value-based medicine structures, or even narrow networks, you're going to have to participate in these programs because all of this information and quality, how you're doing and how you're succeeding is all going to be transparent and it's going to be published. So I think it's very, it's very good to understand that it's not something you just run from. It's very good to incorporate this into your, there are incentives here, but even if there weren't the money, it'd be very good strategically to incorporate these programs. So for OBGYN, as you've seen on the screen, there's 24 measures to choose from. You only need to pick 6, but all 24 are in front of you right now. I'm going to walk through them. Different screenings that I'm sure you do on a regular basis. And as a reminder, we'll be sharing all this with you. Now in pediatrics, for about a 6 clinician practice, about $12,000. So $7,800 your first year, $10,000 your second year, $20,000 your third year, and then $13,000 your third year, and $17,000 your fourth year. Cumulatively, about $50,000 over 4 years. So again, money, as you've heard before, I strategically, please go for it. And again, this is not free money, but it's money that you want to have access to. You certainly don't want that cut from your practice. On pediatrics, there are 18 specialty measures to choose from. And again, you'll need to do 6. So we're going to walk through all 18 here. And there are general outcomes measures as well. Because as I mentioned, you need to pick one outcomes measure if it's applicable, if you can. So you've got to pick, and these are just the general ones. And the quality. So you got to pick 6 quality measures, but one of them's got to be an outcomes measure. And these are the non-specialty specific outcomes measures to choose from. But again, companies like ours, we'll boil all this down for your practice, for your workflow, and pick the ones in partnership with you that are best for you to report on. We're going to actually give you all 93 improvement activities. I'll just show them to you real quickly. The H next to anything would delineate a high priority or high weight. Again, you have to pick 4 medium or 2 high weight in this category for maximum credit. Now, ACI measures, the advancing care information. This is going to replace meaningful use. I heard some clapping there. And that's actually one thing to remember. All of these programs, PQRS, meaningful use, value-based modifier, those all get rolled up starting in 2019 into the MIPS program. You do have to start capturing information for MIPS in 2017, but all of those programs are integrated by 2019. So you don't have to report anything but the MIPS program. So what will it take to succeed financially? Just to kind of highlight, because you just don't want to lose any money that you've earned. So look for the operational efficiency as well as clinical and financial best practices. Optimize your coding and look at coding comprehensively, because again, there's a lot of money there. Usually, like I said, $50,000, $100,000 or more, depending upon the practice, so we can improve revenue, improve cash flow. Claim creation, scrubbing, and submission, getting out that clean claim, working denials. I cover a lot of this in more detail on my larger webinars, but there's a lot of opportunity that's being lost by not following up with denials, not appealing denials tenaciously. Only 60% of practices actually appeal a denial. We appeal 100% of denials. You have to. I mean, you have to be tenacious. It's money that's yours in most cases, but you need to go get it. And then we go to the root cause of why the denial is occurring, and we get rid of the root cause. We mitigate the root cause, so then we don't have denial moving forward. So eligibility verification, authorization management, and best practices there. And then obviously looking closely at payer contracts and variance rates, and setting up KPIs on the financial side as well as the clinical side to make sure that you're achieving the financial health that you want to, but then also setting up the clinical health to make sure you're succeeding in PQRS, meaningful use, and certainly MIPS. And on the clinical side, you want to look to integrate data, clinical and financial sources. That's going to be very key, certainly with MIPS coming along. You got to look for the data integration there and the efficiencies there. And as I mentioned several times, customize your EHR to capture this information, set up your dashboard so you can view how you're doing on a monthly basis, and certainly if not monthly, then quarterly. You can capture and monitor and report on all of the key measures and factors, financially and clinically, for your practice. And you want to implement best practices where applicable, because there's lots out there that you can just run smoother, use Health IT better, reduce clicks, and really have a healthier bottom line, improve revenue by 5 to 15%. That's for traditionally what when we walk into a practice, that's what we commit to, that's what we do. We're improving revenue and cash flow by 5 to 15% by deploying these types of strategies. Look at care coordination across the continuum to optimize outcomes, because this is where payments, certainly in 2019, 2020, and 2021, are going to start to flow through those different care coordination and population health strategies. And then really continue opportunities to engage patients, educate patients, and empower them. They are the most underutilized resource in a medical practice. We think it's everything that the nurses need to do, the staff needs to do, and certainly the doctors need to do, and that's not true. There's a lot of patients can help a lot with data entry, certainly when it's meds and meds they may be getting outside of your organization. You can verify all that for accuracy, but make them do a lot of the work. There's ways to, and also just educate patients, engage them electronically, make them use portals, schedule hopefully through online portals, and that way it's more accurate. It's within certain windows that you want with patients. I mean, there's so much innovation that you can offer by using technology and innovation, and get paid more money. But you want to engage your patients around this and certainly educate them and empower them. So, and for everybody that knows me, that I personally believe that all care providers that intentionally and deliberately engage with new payment and care delivery models and create the right partnerships will have more opportunity in the future than they have today. I've been doing this for 20 years now, and I participate in this every single day, and I know it's true. For additional resources, you can go out there, and the website by CMS is pretty good, the qpp.cms.gov. You can go in there and look for any specific specialties based on your practice. If you want to look at how, we have also this posted on our website, a lot of the best practices, not only the measures, but also how to implement it and other tips and tricks, and then certainly drilled down by specialty. And then also CMS has a great website called innovation.cms.gov that talks about what's happening across our communities and our backyards regarding accountable care, value-based medicine, and that specifically can tell what commercial as well as CMS programs and plans are around you. So with that, I'll turn it back over to you, Alex, for any questions. And again, I appreciate everybody's time. We will have another webinar December 1st. I think it's around noon Eastern that will walk through the entire MACRA rule and a lot more best practices at a high level, and we'll have even more primary care ones coming in December and in January. Back to you, Alex.
Thank you, Justin. We are nearing the top of the hour, so I'll go ahead and dive into our first question. This person asks, can we select a high priority measure instead of outcome, or are we required to select an outcome measure?
So if you have an outcomes measure for your specialty, please use that one. You need to use the one that's for one of them that's in your specialty, and you're given a whole range. But if you don't have any that are applicable to you, or certainly not available to you in your specialty, then you can pick any, certainly a high-weighted one or one of the other ones available as well, just for general. But yeah, there's a lot of flexibility there based on how you how you operate your practice and your workflow.
Thank you. Our next question, how do I find out if my practice is exempt from MACRA?
So I think the most common ways are if you have more than 100 Medicare patients, then you do qualify. If you have less than 100 Medicare patients, then you don't qualify. You could be exempt. If you have less than $30,000 in Medicare allowables, then you could be exempt. And also, if you're a first-year physician straight out of residency, you could also be exempt.
Perfect. Our next question says, I believe you said there are 55 quality measures for family medicine and that we need to select 6 to get full credit. Do you have suggestions on which 6 to select?
That's a great question, and yes, if I knew your practice and your workflow, then